Okay. This week is our week 6 live lecture for patient care and pharmacology. And we're gonna continue our conversation about basically about the contrast aspect of imaging. And the part of imaging where we work with different drugs and we have different drug interactions. So we're gonna kind of continue that conversation. So touched on this last week a little bit, but we're gonna talk about it again this week. So I think one book has its 5 rights of medication administration. One book has that is 6. Um, I lean toward the 6 right more than the 5, but the 6 rights of medication administration is the right dose of the right medication to the right patient at the right time by the right route with the right documentation. That is very important. If we administer contrast to our patients, whether it's oral contrast or IV contrast, we always want to make sure that we have the correct dose. You don't want to give someone more medication than what they're supposed to have, because it can end up having a toxic effect. You want to make sure you're giving them the correct medication for whatever study or test that they're having. You want to identify your patient to make sure that you have the right patient for the exam before you administer the contrast at the right time. So with CT contrast and with oral contrast, barium contrast, when we do our different studies, small bowel follow through, we need to make sure we're giving it at the right time. So time is very important with those tests to make sure we get diagnostic imaging or imaging that the radiologist can read for whatever condition the patient may have. By the right route. Do we know if we have IV contrast, can we give it orally? We know we can't give barium through an IV, so we need to know the right way to administer the contrast or the medication, and with the right documentation. Documentation is important in healthcare. If you don't document it, it's like it never happened. So we give a patient a medication such as contrast or oral contrast. We want to make sure we document that. You want to make sure you document how much was given. If the patient had an adverse reaction to it, you want to document that. So those are some of the things we need to think about when we're dealing with the pharmacology aspect of imaging. So quick question, just to review, the 6 rights of medication administration include the right dose of the right medication to the right patient, B, the right patient with informed consent and verbal order given, C, the right order with the right IV access and assigned DNR, or D, the right dose with standing orders and with informed consent. You can go ahead and answer in the chat. Okay. So yes, the correct answer is A, the right dose of the right medication to the right patient. So now we're gonna kind of talk about what contrast is made up of. So how is it contrast? What makes it contrast? So we'll talk about a little bit about that. So with radiopaque contrast media, you have two kinds. You have negative contrast and you have positive contrast. So your negative contrast typically involves the use of gases to reduce or decrease the attenuating ability of structures filled with gas. Results in increase in radiographic density. An example of negative contrast is room air introduced into the colon as a part of a double contrast enema. Then we have positive agents or positive contrast. This increases the attenuation ability of the structures containing the positive contrast. So the affected anatomy appears whiter, or if it appears whiter, we say it has decreased density compared to the surrounding structures. Radiopaque contrast is an aqueous agent. That means it's water soluble and it mixes readily with the blood and bodily fluids. So contrast is made up of iodine compounds, and those iodine compounds absorb radiation to a greater degree than the blood or soft tissue. So this is what causes the organs and blood vessels to stand out with that white appearance or brighter appearance. And this appearance is referred to as a positive contrast or positive appearance. So we know barium sulfate and iodine compounds are going to give us this positive contrast. So it's going to give us that brightening on our images. So iodine molecules are responsible for the silhouette images projected on radiographic film because they absorb photons, allowing fewer to pass through for projection onto radiography. So radiopaque contrast, they are high density pharmacologic agents that we use to visualize low contrast tissues in the body, such as the vasculature, kidneys, GI tract, and the biliary tree. So if you go into a modality like CT, and even they're starting to use contrast in ultrasound and in mammography, and we use contrast also in MRI. But usually what we're looking for is to enhance the area that normally, if wouldn't be given the contrast, would just be similar in color. So an example of that is when we take an X-ray, usually we see a lot of whites, grays, and some black. When we look at CT images and MRI images, we get grays. We get variations of grays, and we get white. We get some black. So when we are looking at like a patient's liver, if you look on a non-contrast CT, the liver is gray. We can see like the shape of it. But if you give that contrast, it enhances the brightness of the liver. So the liver, instead of being a darker gray, it gets a little bit lighter. Then you can see the vasculature of the liver. So it works like that in showing those different body parts, organs, and vasculatures. So the most frequently prescribed contrast is going to be our iodine and barium. So one thing about contrast, you will sometimes hear people, they don't call it radiopaque contrast media. They may call it contrast, they may call it iodine. People kind of use them interchangeably. But the contrast has iodine in it. So that's why a lot of times people will say, have you had the dye before? They use that too. So it does have a level of iodine compounds in it, but it's not a large amount of iodine. So when we say radiopaque, remember we're saying that it's positive, and that means that it demonstrates less density or brighter than surrounding structures. Like I talked about, it is aqueous, so that means it's water-based and it's readily absorbed by the body. And some examples of tests that they're used for are IVPs, cystograms, intrathecal injections, and then hysterosalpingograms. We're gonna watch this quick video.
Hi, I'm Dr. Jeff Pastor. I'm an assistant professor of anesthesiology at the Mayo Clinic in Rochester, Minnesota, and the chair of the Division of Neurosurgical Anesthesia. I'm going to be discussing an article which is going to be published in an upcoming issue of the Mayo Clinic Proceedings called Iodinated Contrast Agents, Clinical Pharmacology, Uses, and Adverse Reactions, a primer for the non-radiologist. Contrast agents are drugs which have long been used to enhance imaging of anatomic boundaries and explore physiology. Iodine-containing or iodinated contrast agents have become the most widely used subclass of these drugs. Given the large utilization and diversity of both imaging modalities and patient populations requiring imaging, physicians from all specialties will either administer or care for patients who have received these drugs. As these drugs also have risks and side effects, it is important for all physicians to be aware of the potential adverse effects associated with iodinated contrast agents. In order to familiarize the non-radiologist physician with the pharmacology of iodinated contrast agents, Dr. Eric Williamson from our Department of Radiology and I decided to write a short review. We begin by describing the fundamental chemistry and pharmacology of the four classes of iodinated contrast agents, which consist of monomers or dimers of benzene rings which are tri-substituted with iodine atoms and either contain or lack an anionic functional group. Then we discuss how these properties relate to choices of agents for the three major routes of administration, which are intravascular, enteric, and direct. Intravascular is by far the most common and can be divided into either intraarterial or intravenous injection. For rapid intraarterial administration, the viscosity of the formulation is of key importance, as greater viscosity may limit the speed of injection and thus arterial opacification. Require warming of the contrast agent solution from room temperature to 37 degrees centigrade may assist in reducing viscosity. Also, choice of formulation with a lower osmolality can reduce patient discomfort, as venous injections are usually performed to facilitate solid organ enhancement. The injection is often performed slower than that of intraarterial injection. Thus, agents are generally chosen based on their safety profile. Extravasation of these drugs may lead to tissue necrosis, and as a general rule at our institution, plastic surgery is often consulted for extravasations greater than 100 mL. Enteric administration is also quite common, and iodinated contrast agents are preferred over barium if a bowel leak is suspected, as extraintestinal barium can lead to inflammation and adhesions. The side effect profile of these drugs following enteric injection or following direct injection, such as during arthrography or myelography, is much more favorable than following intravascular injection, as the immune system and the kidneys are exposed to much less drug than compared to intravascular injection. We allocated a good portion of the article to address side effects. Some of the more common and fortunately minor and often self-limiting adverse effects include discomfort on injection, nausea, vomiting, and hemodynamic changes. We then focus on the three major types of significant reactions, which are acute and delayed reactions and contrast-induced nephropathy. Acute reactions occur within 1 hour of administration and are usually either anaphylactic or anaphylactoid in nature. Patients at greatest risk are those with either a history of asthma, atopy, or a prior acute reaction to these drugs. In patients at risk, one should first consider alternate imaging that will not require the use of an iodinated contrast agent. If this is not possible, ionic monomers should be avoided. Pre-treatment with corticosteroids, with or without antihistamines, may not prevent severe reactions. And for those patients that do have severe acute reactions, the ABCs of airway, breathing, and circulation, as well as the administration of epinephrine, should be the primary focus. Delayed reactions occur between 1 hour and 1 week following administration and are generally thought to be T-cell mediated type 4 hypersensitivity reactions. A rash and pruritus is by far the most common presentation. Patients at greatest risk are those with a history of a reaction to iodinated contrast agents, those being treated with interleukin-2, or patients receiving agents from the non-ionic dimer class. In high-risk patients, use of alternate imaging modalities should be considered, and if that's not possible, drugs from the non-ionic dimer class should be avoided. Pre-treatment with corticosteroids may lessen the severity of the reaction, and treatment is generally based on symptoms and can include steroids and possibly antihistamines. Contrast-induced nephropathy is a reduction in renal function following the administration of a contrast agent. Although it usually follows a benign course, it can in some patients prolong hospital stay, lead to a chronic reduction in renal function, and increase overall mortality. Risk factors include pre-existing renal dysfunction, states of reduced renal perfusion such as dehydration, and simultaneous use of other renotoxic drugs. Type of iodinated contrast agent and route of administration seem to impact risk of developing contrast-induced nephropathy, with the greatest risk occurring following the use of ionic monomers and following intra-arterial injection. Treatment should begin with prevention. One should consider alternate imaging modalities, and if that's not possible, a low or isoosmolar agent should be considered and their volume should be minimized. The use of concurrent renotoxic drugs should also be minimized if that's possible. In our manuscript, we discuss the utility and effectiveness of other modalities such as hydration and the use of N-acetylcysteine, dopamine, phenoldiprem, and hemodialysis. We invite you to look at the manuscript for specific details.
Okay. So just kind of a better explanation of contrast, how it's used, the makeup, what makes contrast. All right. So there are three broad categories of intravascular contrast. You have high osmolality ionic, low osmolality non-ionic, and low osmolality ionic. So your lower osmolar contrast agents, as compared to the higher ones, are more toxic, and they're less likely to initiate an allergic response and more likely to cause nausea. So you heard the man on the video talking about nausea being a side kind of a side effect of if a patient is given contrast. And you will have patients that get nauseous, but it just varies from patient to patient. So osmolality, this is related to the concentration of an osmotic solution and has a relationship to the patient risk of reaction. So when I think about the osmolality of a of contrast, it controls the distribution and movement of water between body compartments. It is the number of milliosmoles per kilogram of water. So you have a high osmolar contrast, it's associated with more adverse reaction. And then you have a low osmolar contrast, which is associated with fewer adverse reaction and increased patient comfort. And majority of the places nowadays use a lower osmolar contrast. So then viscosity. This is important in determining flow rate, which if we use a power injector, which is done, it's done in CT mainly. How fast the injection time you're gonna inject the contrast, what size needle you use if you start the patient's IV. So higher iodine concentration increases viscosity. So our contrasts that have a higher iodine, it has an increased viscosity. So when we talk about viscosity, I like to refer to it's like pancake syrup. So pancake syrup is kind of thick, depending on what brand you buy. It's pretty much sticky. That's how contrast is. If you've ever dropped a bottle of contrast or were able to kind of feel it, get it on your fingers, it's sticky and it's kind of thick. It's probably more like if you buy off-label syrup, so kind of like the store brand pancake syrup. It tends to be a little bit thinner than say like a log cabin syrup. But what happens is you'll see places that warm their contrast. So the reason why they keep their contrast warm is because if you keep the contrast warm, then it makes it flow a little bit easier. So it kind of thins it out. So think about you were eating a waffle and you put some syrup on there and you put the waffle in the microwave for a couple of seconds. that heat thins the contrast out. Or when you go to a restaurant nowadays, they usually they'll sit their syrup in hot water in little individual bottles, so when they bring it to you, it's warm, and when you pour it, it pours a little bit easier. So that's kind of what viscosity is referring to when it's referring to contrast. Then we talk about toxicity. This is related to the medium's chemical configuration, iodine concentration, osmolality, ionization characteristics, injection rate, and the dose. And we know that if a patient gets too much of a specific drug, it can have a toxic effect. Then we go to ionic and non-ionic. So ionic compounds are going to dissociate into charged particles, an anion and a cation molecules in the blood or water. Then you have non-ionic. This does not dissociate it into anion and cation. It's designed to reduce the frequency of adverse reaction. And some examples of non-ionic contrasts are going to be IsoView, Omnipaque, and OptiRay. So this is a chart from the textbook. We have our low osmolality, non-ionic intravascular radiopaque contrast media. These are some of the more common contrasts that you'll see out in the field. So you see you have Omnipaque, IsoView, and OptiRay. And these are typically used in CT. Now MRI does use contrast, but their contrast is a little bit different than CT contrast. But it is an agent that is used in MRI as well. So some things to remember. With intravascular contrast, it consists of large molecules passing molecular weights ranging between 600 and 1700 with poor lipid fat solubility. Consequently, IV contrast does not cross cellular membranes well and is primarily distributed into the bloodstream. The newer low osmolality ionic contrast consists of 6 iodine atoms per molecule and dissociate into 2 osmotically active particles. These are considered to be ratio of 3.0 media because there are 6 iodine atoms and 2 dissociated particles per molecule for a ratio of 6:2, which equals 3:1. In patients with renal impairment, several days may be required for complete excretion of the contrast from the patient's system. Consequently, these patients have much lower to no opacification in the kidneys because up to 50% of the contrast may be eliminated via the hepatic biliary system, thus opacifying the biliary and GI tract. And then when a patient receives contrast, one can expect to see a transient rise in intravascular osmotic pressure. So fluid from surrounding tissue is drawn into the vascular lumen to dilute osmotically active particles to equalize pressure between intravascular and extravascular spaces. This will cause fluid extractions from the red blood cells, endothelium, and extravascular space. So that just kind of tells you when the physiology of it. So when we inject the contrast, what is it going to do? And how does it get to the point where it interacts with your system to make that bright color? So anytime we have patients who we administer contrast to, there's a chance they can have allergic reactions. Allergic reactions can be mild to severe. There are no predictors. And if a patient has a known contrast allergy, they're usually pre-medicated with antihistamine and a corticosteroid. Now, it depends on how severe their previous reaction is, because if you had a patient that had a previous anaphylactic reaction to contrast, it's recommended that that patient never have contrast again. So an allergic reaction is a sensitivity to iodine or some other component of the makeup of the contrast. It may occur in patients with poor heart and kidney function or due to overdose of the contrast. So it's important that we check patients' renal function. We use BUN, creatinine, and GFR. Those are the three tests that we use to lab tests that we look at to determine patient's kidney function. So the renal function must be checked prior to administration, and any abnormal levels must be reported. With our diabetic patients, this predisposes them to renal complications, so it's always important to ask them about metformin. Now, some facilities, they disregard that, but some facilities still have patients discontinue metformin 48 hours after they're given the contrast. It just depends. It depends on the doctors. It depends on the facility. Adverse effects elicited by contrast depend at least partially on their blood tissue iodine concentration and osmolality and their calcium chelating, anticoagulant, and immune system stimulating abilities. So with our mild contrast reaction, some symptoms include warmth, flushing, metallic taste, coughing, nausea. So for test taking purposes, you all, if they ask you a question or you get a question on a test and it tells you a patient is experiencing warm, flush, and metallic taste, is the patient having a mild contrast reaction? The answer is going to be yes. But in real world scenarios, these symptoms are more like a side effect. So if we give patients contrast, more than likely they're going to experience one of these things. A lot of times patients get like a hot flash. So that's the warmth part. They may get warm all over. They may get warm in certain areas of their body, like their neck. It just depends. Everybody's different. The flushing and metallic taste, that can happen when we give patients contrast. The nausea, usually that can happen. What we normally do if we have a patient that's known to be nauseated when they get the contrast, we take an alcohol prep and kind of fold it and put it under their nose. It's something about them breathing in the alcohol kind of distracts their system. But those are things that are common, and I like to call them side effects more than reactions. So that's just my 2 cents on that. Moderate contrast reactions, your symptoms are erythema, your urticaria, and bronchospasms. If you have a patient that experiences any of those symptoms, then they need to have an antihistamine orally, IV, or IM. They may even have a bronchodilator drug by inhalation for bronchospasms. You have patients that experience a vasovagal reaction. So symptoms of this reaction is diaphoresis, hypotension, and bradycardia. If you have a patient that has a vasovagal reaction, you want to place the patient supine, feet elevated 20 degrees, and head elevated if breathing is a problem. IV fluids and atropine administered for bradycardia. Patients do have vasovagal reactions when they get contrast, but a lot of times we see patients have vasovagal reactions when we start IVs on them to have the test. A lot of times we do request that our patient be NPO. So NPO means nothing by mouth for at least 4 hours before the exam. So we have a lot of patients that come. They may have like a 9 o'clock appointment and they come in, they hadn't eaten anything since maybe 1 or 2 the day prior. So it's some about that, them not having anything on their stomach, and kind of when you start the IV, it can cause the patient to have a vasovagal reaction. It's more like the patient is starting to pass out. Can make you feel like you're peeing yourself. That's correct. A lot of times that's the most common thing that happens with patients, is that when they get the contrast, it makes them feel like they're peeing on themselves. And we always warn the patients about that. So, majority of the patients will experience that. You have some patients that don't experience, and they experience the warmth in different areas of their body. So it just depends on the patient. And then we have a severe anaphylactic reaction. The symptoms are warmth, tingling, itchy palms or soles, dysphagia, laryngeal or bronchial edema, respiratory arrest, cardiac arrest, seizures. If you have a patient that you think is going to an anaphylactic reaction, you need to, number one, get help. Maintain their airway epinephrine is usually administered by IV, other drugs administered as needed by the code team. Usually at this point, we're calling the code. We're going to get our radiologist and our nurse really quickly and let them kind of take a brief look at it, and then they'll tell you whether to call the code or not. But more than likely, if they're getting to that point with the reaction, we're gonna have to call the code team. So these are just some pictures of what a contrast reaction can look like. The picture on the right is going to be more severe with the hives and the redness on the torso. Is kind of majority of the torso is covered, and then the picture on the left is more of a milder reaction. It's kind of isolated to that just one area, but you can see where the redness is. So that's all I have for you guys tonight. Here's your study guide. Do you all have any questions for me before we close? Okay, if you don't have any questions, I hope you all have a good rest of your evening. I'm gonna leave this up for anybody that needs to kind of take a longer look at it, or if you need to take a picture of it, I'm gonna leave it up for just a few minutes. Don't forget to type your name in the chat box for outgoing attendance.